Hi, everybody. Hope you're all well. I'm such a bossy boots. You are all sitting in the wrong place. One up. I said this backstage. Thank you. Here, yeah, that's my place. So just one up. And do you want to sit next to me?
Yeah, I would love to.
As we have discussed.
Yes, I would
Let's go. So let's just move one more. My word.
You need to move, Alex. No, I can't do it.
And it's not because there's an OCD problem here. No. It's because of camera angles and a whole load of things you may not understand, right? But I also want to make the point, I did repeat the instruction twice to you two because I somehow had an idea that this is how it was. But anyway, let's get on. Okay, how's everybody doing?
Good.
All good?
Thank you.
Yes.
Good. So we all know we've been talking about NHI for a very long time. And we also know that right at the very beginning, it was kind of like niggling around the corners and made a few talk shows, but that was it. What brought it to the fore, of course, is what happened just before the elections in terms of some signatures. Not so sharp, eh? Must I repeat? Anyway, you know what you're dealing with now, right? But I think the truth of what we must all accept is not a question of should we, it's a question of it is, right? So, but let's try and work out the nuts and bolts of how this is meant to happen. So I'm going to start with you, Dr. Jacobs. Now, it is a commonly held belief that NHI will not be implemented fully from day one, but in phases over a period of time. So let's understand that. Is that true?
Yes, that's absolutely true, but let me count for you. We're 4 days away from the end of the second month, since the 15th of May, so definitely not day one. And I don't think also within the next few days. We need to understand that this is a programmatic approach, this NHI. It is something that is a process. It is something that we needed to do, that we've been encouraged to do since 1961, and also according to the African Charter in 1981. And then, of course, it was a resolution that we should bring better access to quality healthcare for all the people of South Africa. Now, that's been coming on for a long time. We only need to look at where we are now currently to see where we ought to be going. And surely we are not going to be able to do that in the blink of an eye or very quickly, because our backlog that we have in terms of recovering from what we had in the past is something that is going to be a work in progress.
So then I like pictures, because if you paint a picture for me, then I can almost see it. So paint the picture of what should South African citizens expect to see within the first year of implementation, and then right at the very end when NHI is implemented fully.
Yeah, so when you look at the Act itself, which I was very fortunate to have worked on for many years, since 2009 I've been working on this animal called the NHI, and then fortunate towards the end to be deployed to Parliament where the processing of the NHI bill was taking place. And just looking at that in itself is 13, 15 years ago. So, and taking South Africa back to the past 50 years and taking us to where we are now in the last 30 years, we have not really seen a great improvement in the healthcare that is being provided to our people because of many constraints and many reasons. So we're saying, let's look at these reasons and let's look at the challenges which we have been experiencing. And what is it that we wish for each and every person to have? I think always for me, health, that's why I became a medical doctor, is I wanted to be able to provide hope of a better life for all people from a health perspective, because I also believe it influences the rest of their lives, economically, education, etc. So what do we want to see to answer your question? We want to be in a position where anybody can go to a healthcare facility closest to them and not having to pay for that care and being able to receive good, adequate care that is adequate to the condition which they have at that point in time. And I think that's what we're really striving towards. And so they don't have to pay for it. You don't have to face financial hardships in order for you to be able to get that care.
But break it down for me, right? What should we see in the first year? What do we need to see at the end of it?
Right, so we have decided we have two phases. It's phases 1 and 2, 2023 to 2026, and then 2026 to 2028. We are already now in 2024, and we know the President had signed this off on the 15th of May. So already there's a bit of a backlog here. What it really means is that we're going to look at health system strengthening. We're going to look at improving the legislation, not only the NHI legislation, but also the other legislation. We're going to look at putting the necessary fund in place, and the fund itself would have 11 board members appointed by the minister. And we're going to be looking at the other committees which need to be put in place, for example, the Benefits Advisory Committee. So it really is a work in progress. Apart from that, we need to look at the facilities itself in terms of its compliance, infrastructure development, even working with the medical schools, even looking at the training of nurses and doctors, etc. So it's a whole new way of looking at healthcare holistically instead of looking at only in silos and having different people being responsible for different facets of the care of the people.
So you know you didn't answer the question, right? so you remember what I said about the pictures in my head,
yeah.
Right? So you tell me, what must I look forward to seeing in the short term, and what must I see in the long term?
In the short term is the restructuring, is the work that the department would have to do in order for them to comply with the Act.
Okay.
And the minister must comply with the Act. That's in the short term. I asked the question when I was dealing with this bill, I was asking myself, so what happens the next day after the president had signed it? That's virtually what you're asking. What happens on Monday? What has changed? What is going to change? And right now, nothing has changed because we understand that we can't make a promise to people that within a month or 2 or 3 or 1 year we'll be at this point in this work. What we are hoping for is that sooner than later we'll be able to say to people, you're now all registered on a system, you have a registered service provider, you have a registered clinic where you go to, you're going to get this basket of services at a primary healthcare level, and that there would be referral to any other care that you require.
Okay. So, Prof, just based on what we're saying here so far, I mean, it sounds like the perfect plan if it's outlined in those specific words, but do you have concerns?
Yes, a lot of concerns. And I would say, first of all, we don't have a plan. It's not a plan implies that you really clearly know what you're going to do next and have a direction going forward. And the problem that we have is that what's in the Act itself is only part of the proposed reform. So there's ancillary reforms that fall outside of it. So the Act itself can't implement the overall policy framework. But what it envisages, essentially, is that it anticipates that it will introduce new taxes in order to tax the equivalent expenditure that medical schemes are spending and allocate that to a single fund that will now provide universal coverage through a single fund. So that is actually a stated objective of the Act itself. And the problem is that there has never been a feasibility assessment of that specific proposal. Now, no country in the world provides universal coverage through a single scheme. They do not do it. The NHS does not provide universal coverage through a single scheme. It offers access to healthcare through a scheme that is universally available, but it doesn't stop you from taking out private insurance. And there in the UK, they failed to regulate it properly. But in many other countries, they co-regulate. They basically harmonize all your private and public systems to achieve universal coverage. And there's a very good reason for that. And that is that you cannot actually fund a scheme like this just through taxes. And medical scheme contributions are not taxes. People pay them because they're getting something back for it. And so you cannot actually raise the amount of money to actually provide what is promised in the NHI Act. So the problem is that it's a set of promises. It's not a plan. And there is actually no feasible way of implementing this framework, even if you say you're going to phase it in over a long period of time. Even scalability features of this plan are next to impossible. And quite aside from that, it proposes that it's going to change the whole multi-level system of funding the public sector, that all the money going to provincial health departments, that the functions are going to shift to the first tier of government. This is an extremely complex proposal. Forget about medical schemes. Doing that is going to be a technical nightmare and is very unlikely to happen over time. So the question is really whether, in fact, a more feasible universal coverage strategy should have been proposed. And there is a distinction to be made between plans and strategies. And strategies mean you've prioritized your most important interventions to achieve your most leverage effects as fast as possible. This is not that. And we have many issues that need to be addressed. And since 2004, we have had no systemic reforms in the public health system and in our national health system. And so government has basically sat on its hands instead of actually reforming the health system, but made this promise.
So I'm going to come back to you in a bit, but I want to just bring in now Dr. Mutudi. Again, what are your concerns?
I think when you try to intervene, you must be clear about what is it you are trying to solve. That's the first thing. Secondly, you also have to be sure that what you're proposing is appropriate. Now, we could probably spend the whole day interrogating what problems we're facing, whether you're looking at the public sector or the private side. But let's look at
Dr.
the
Mutudi,
intention.
just speak up a little bit.
Okay.
Just a bit more.
Okay, so I'm saying that to try and get to the answer, we then have to examine what the intention of universal health coverage is. We're talking about offering essential healthcare services. So you should have gone back and said, what is it that the population actually needs? What is it that is absolutely important? The United Nations and WHO talk about a continuum of care that includes promotive, preventative, treatment, rehabilitative, and palliative. The first thing is you have to ask how much of that are we actually providing, and how much do people actually have access to? Then you realize how much work we actually have to do. Then you say, does the NHI Act actually offer us that? And the answer is no. And the problem is the focus is very, very narrow. We want to achieve universal health coverage, but we're fighting over the financing component and almost ignore in totality everything else that is important. We've got lots of frameworks. The WHO has got templates that have been published, but we are not paying enough attention to them as we should, and we're focusing on the procurement and or the financial aspect. And that's, in our opinion, is the biggest problem. So we have a problem, and we can talk for days around the issues around leadership and governance, for example. And that has been the downfall of healthcare provision. And you can just look at the impact of that. You've got a healthcare budget that is allocated to provinces. Before you are able to provide any healthcare services, and you put on maybe a province like Limpopo, about 60% of the allocation goes to salaries. Some of it has to go to provisions for medical legal cases. Then there's unpaid monies for services that were rendered or supposed to be rendered in the previous year. So, and you end up with nothing. And I'm just giving this as a specific example to say our measures are not appropriate in terms of addressing the problems that we have.
Prisha, any concerns?
Well, I think I want to go back to your original question posed to Dr. Jacobs, because think you needed pictures, and I wanted to give you a few pictures. Or just to contextualize where we are now. The President's signature of the Act in and of itself has brought nothing into effect. There's a two-stage process when we bring law into effect. The one is assent, the signature, and the second is the actual promulgating into commencement, the enactment of provisions. We've had none of that. So we are 2 months later with not a single provision in the Act that has now commenced. And so we are, as Dr. Jacobs suggested, a year and a half down on the first phase, and there's not one piece of the legislation that is actually in effect. And so to add to the pictures you want to see, you currently only have one, which is the signature, and a blank canvas for quite a while, as we would understand, given that there is a flurry of litigation that's currently happening challenging the assent and the Act in and of itself. So that's the picture for you. In terms of comment and concerns, I think we must, at least from a starting point, and whenever I enter into these debates, and I spoke with the Sanlam group last year as well, it's not this idea of private versus public, and we are protectionist, and we want to necessarily only retain a very functional private sector. Both are fraught with problems and issues, and both require interventions. My standard line when advising clients, of which I have a grouping who's going to challenge the Act, is we don't believe this to be the appropriate intervention. The use of the language of universal health coverage is very important because, as Dr. Jacobs said, that is what we actually committed to provide. We didn't commit in 1961 to provide national health insurance. We committed to provide access to quality and affordable health care. And we have a public sector that was meant to do that and then has not done it systematically in 30 years into democracy. The issue for me is the intervention that the state has chosen as national health insurance, and then the mechanics of that insurance as contained in the Act, I believe are problematic both from a constitutional perspective as well as what Prof. van der Heever said, a practical economic perspective. So I have constant issues with we all want to aspire to the laudable goal of universal health coverage. What we have chosen as a state, I don't believe is going to get there.
So, Zingiswa, are you concerned? Nice idea from what I'm listening and what I'm hearing from everybody. Fabulous. But we're missing more than a few nuts and bolts according to these individuals.
Debbie, thank you. And firstly, we want to say that as COSATU, and I would speak on behalf of workers in South Africa, who do not have access to healthcare, quality healthcare as the private sector would be deemed as providing. Our support, firstly, for the national health insurance is, we see it as a step towards achieving the universal healthcare coverage and towards us having the comprehensive social protection as an ultimate end. Now, you are having a healthcare system, and I think it was depicted at the beginning by Gerald, of a private health sector public healthcare sector that caters for 84% of the population. And you are spending there about 279 billion per annum. And you have a private sector that caters for 16% of the population, spending almost the same amount. You have workers that have a medical aid but still cannot afford healthcare in this country. So we have a problem. We have a problem of workers that continue to pay every month without missing a payment towards their health coverage. But when they are admitted in hospital, they are told by medical covers that you have depleted your funds. You still need to pay. You still have a core payment that you need to do. And these are realities that ordinary South Africans are faced with. Whilst you are debating which is important, the nuts and bolts of it. But you have then those that are working poor, who continue to go to work, who still cannot afford even primary health care in South Africa, because you have to stand in a queue in a Baragwanath hospital from 4 a.m. until your shift ends and you have lost an income and you did not get your...
You see, we're not debating that. That's fact. Whatever you're saying, I work in all over South Africa. For the last 30 years, I've seen that. Everywhere you go, people who need do not have. I've seen that. The question that I'm asking you is, according to what's been put out here, do you have any concerns? Because it's a great idea, it has to happen, but what are your concerns about the plan? Do you have any?
Our concerns, I think, would be in terms of the pace of us moving towards us implementing this national health insurance, because it's critical. And the reason why to us it becomes a main concern is to address exactly the same issues that everyone talks about. Because to understand and to see them happening, but to be experiencing on a day-to-day, when everyone is talking about we are not preventing our sector, but at the same time we're talking about these nuts and bolts, can we South Africans sit down and say, what are the bolts? What is the size? How do we put them together so that this vehicle of national health coverage begins to move forward in order for people of South Africa, particularly the black majority who are poor, are able to have access healthcare coverage?
Because you do accept, COSATU, I mean, you guys have the numbers, right? So if somebody starts talking NHI, etc., especially before an election, and then there are signatures, they would want you on their side. But what I can see you doing, and we had a conversation earlier, is you standing back and saying, great, show me how it's going to work. Otherwise, we all just get bluffed here in the system, and then nothing happens. So, Dr. Jacobs, I know you are dying to... Oh, wrong turn of phrase there.
All right. Not dying, dying to talk.
Yes, dying to talk. You want to have your say.
Yeah.
So I'm going to just structure you a little bit here, right? What they're all saying is what we have here is not really a plan. It's a set of empty promises. You haven't looked at international examples. Nothing has happened. And perhaps, in fact, you guys have the wrong recipe. How long you said you're working on this?
2009.
Long time.
Yes, but we have had such a long time of unequal healthcare to the people.
Yeah, but just answer these questions, right?
I'm going
in terms
to
of what
answer,
they're
but
saying.
the point is it's a long time, and what's being said is not really true. Why I spoke about the 2 months is not forgetting that life happens. For example, we had elections, we had a new minister to be appointed, the act is very clear.
Yeah, but the presidency knew that before it did the signature.
President can't appoint according to the act, and the president only signed off on the 15th of May. So now, that's why I mentioned the 2 months, is that life does happen. Life has happened to us. Life has happened to the poor people. They've not been able to get good quality healthcare in the past. We're saying all people have the right to have that good healthcare that we as South Africa must provide.
You're doing that thing again.
Yes. So, you see, I need to make a point here that it's about equalizing the playing field.
We know that.
And then we hear some people say we don't have a plan. How can it not be a plan? If the plan is let's change the legislation, let's put something on the table that forces everybody to act in a particular manner and make sure that people comply with this. That's the plan.
And when they say it's a set of empty promises, what would you like to say in response?
Well, how can it be a set of empty promises? We are 2 months down the line. There's work that has to be performed. The task has been given to the minister. Some people want to talk about the powers of the minister, but according to the legislation, according to the act, it's within the ambit of the minister to make his appointments. His very first task would be to appoint the NHI fund board. That would be his very, very first task in terms of this. Then he'd have to make sure that all of the other boards are appointed along the way, because there's work that needs to be done.
But you see now, that's a you problem. And I'll tell you why I'm saying this. It's because it got signed before the election. Why didn't you sign it after the election then? And then we would have had 2 months. The 2 months is still to come. We're not wasting time.
I didn't ask the president that question.
No, I know.
Yeah,
but no, that's true.
Apologizing for that one.
I get that. But I mean, you're speaking very confidently. And my point is, speak to what these guys are saying. They're saying, don't bluff us, make sure it's there, put it down. We're not seeing anything. The point that Felicia made was that in terms of picture point of view, since all the picture is of a signature and that's it.
That's what I'm trying.
We all want this to work. Let's just understand that, right?
That's what I'm trying to address, because a lot of these things are being repeated over and over by people who have a particular viewpoint. I always say go and read the bill or go and read the act.
You also have a viewpoint.
Go and read the act. Make sure that you fully understand what is captured in the act, and then raise the points which you think are contentious
points.
You
read it, or you're sitting here not doing your homework. You
Yeah.
read it.
You read it.
We all read it.
We've read it.
They read it.
We've read it a few times.
And then really go and look at the one point that's continuously being raised is this one of constitutionality, for example. I was the leader of the group that was looking at this bill and looking at the constitutionality and who had consultations with many, many legal experts. So it is fine if there are people who say it's not constitutional. I say as the chairperson of that portfolio committee that it is. We'll get to the point, as we now have heard, that there are people who've gone to court, and we will get to the point where it will be tested. So whatever is being said, which is, from my point of view, not rational, and I want to really address each of those irrational points, but I think I don't really have that opportunity. I hope there will be more opportunities so that we'll be able to address each and every one of those points independently.
Don't worry, I've cherry-picked a few and we'll put it to you
Thank
in just
you.
a bit. But I think let's get down to source, because often discussions like this, we tend to forget the actual people that it's meant to assist. So let's get a view from the street. Let's have an understanding of what ordinary South Africans have to say.
So I think my current understanding about it, I find it to be a very progressive policy to be implemented in South Africa, considering the inequalities of the country, and also, especially also when it comes to public health facilities, which I think so much work still needs to be done. And also, as I mentioned earlier on about the inequalities, it's going to be able to allow, because it's very holistic in nature, it's going to be able to allow people also who are not able to afford, but to be able to get the best healthcare services. But the only concern I have about it is in terms of its implementation, because it's good on paper in terms of policy, but the implementation, considering the outcomes in other countries where it kind of failed to an extent, because it led to so much overburden in terms of employees and so much also turnover rates. But now I'm not sure, because we also have an issue of unemployment within also our doctors who are recently coming from universities. So I'm just looking forward to see how it's going to be implemented.
I have heard of it. So I basically understand that they are trying to provide healthcare for everyone, trying to do away from any like medical aids and everything, and just making sure everyone has equal access. I don't personally think it's going to work. Doesn't work anywhere else that they've implemented it. The current healthcare system also is obviously not the most efficient, so I think they should rather focus on that before they put a new thing into place.
Yes, I have just heard that President Ramaphosa has, released a bill recently before the elections. So I'm aware of it. South Africa will obviously get free medical aids in this. That's what I'm currently aware of.
I think it will be a long time before it comes into force. I'm not entirely happy with it. As long as we can keep our private medical aid, it will be all right. But if we're forced to take national health, I think that could cause problems.
I think I'm for it because it will also help us to get quality treatment. At my age, I realize that life is very expensive. When you go there for checkup, you get that you are short of this or short of that, you are at the brink of a particular disease, and all that affects a person who is aged. They come left, right, and center. So you need to have what you call enough money to get health attendance. But if not, I'd like for you. So in that way, I for one, I will say national health insurance will be fine, but they can make their own what you call category, that those people who can afford, let them have their own what you call a structure. But for general populace, really, I think we need it. We need it.
I don't think it is. South Africa hasn't got the funds for it right now. I think there's a whole lot of development that needs to happen in our country for that to work. And if you look at the NHS in the UK, which is actually bankrupt, it's a very, very bad idea right now for South Africa. It doesn't mean it can't work in future, but right now there are other bigger problems, so we need to solve first.
Okay, let's just pick some of that and have a quick chat around it. So the international examples that you mentioned a little bit earlier, Prof, just summarize it for us again. Has NHI as a system worked in other places around the world? Could we do better? Because, we think we're different with everything, right? So are we going to just be able to make it swing?
There's no other country in the world that has what we're proposing. So it's important to note that what's being proposed is that you'll create a state fund, and then you're going to prohibit people from being able to take out additional coverage. That prohibition is a very unusual feature of this, because why would you do it? Because if you're principally concerned about people accessing the public sector, and you want to increase taxes in order to fund that better, why do you have to shut down medical schemes to do that? You can increase taxes if you can, and you can redirect resources within the state to improve what goes to public health care. That's typically what you do internationally. So what's very odd about this proposal is its draconian nature. The assumption that it can actually squeeze everything into this national fund, this ISCM structure. And it's worthwhile noticing.
Don't be mean. You didn't have to bring that in.
It's not merely an analogy, because running ISCM is orders of magnitude simpler than running a health system.
So let me give Dr. Jacobs a chance to answer that.
You see, it's all... It's very difficult. It seems like I'm defending something which others...
No, don't defend.
I'm not
just
defending.
Speak your truth.
I'm speaking. What I mean by that is, I really mean that's the truth. Because there are things which are being raised, and these things have been raised for the last number of years, which is not really true on platforms such as these and television, etc. This is not draconian. Let me ask a question back to any of my members here, of the panelists. How else do they propose are we supposed to correct the challenge of inequality in healthcare right now?
You see again now, just answer what he's saying.
I'm answering,
No, you're taking too long.
Why would you need to
just answer what he's saying.
Why
I'm saying it's not true that there's no other country. There are many other countries.
Yeah.
There's Thailand, for an example.
Say that.
There's Australia,
Thailand
there's New
doesn't have
Zealand.
this.
The form is just a little bit different. The difference with them, new countries who didn't have the money, we have a country where there's a lot of money, it is kept in a purse by some people, other people have nothing. We need to put it in one purse. We need to be able to provide to everybody. We cannot have the separation as we have going
Okay, last
forward.
comment on this issue.
So just to clarify, in the case of Thailand, they introduced a scheme to cover a group of uncovered people. They didn't introduce a single national fund to cover everybody. There are multiple funds operating in Thailand. This type of misinformation has been used in this. Countries are being referred to that do not have anything to do with the kind of proposal we have in South Africa. And a developing country cannot have a single fund that funds everybody. It will never, it's impossible, and no industrialized country even attempts it.
Can I call you Kenneth?
Yes, please do.
Okay. Because we seem to be doing
we're
all the
friends,
talking.
we get along
I know,
so well.
I know.
We're getting along.
So Kenneth, he says no. That's not like what you said.
No, he's wrong.
Okay.
Right.
Google it.
He's wrong.
At the bottom of it is two different. All those other countries are different from us. We have a small minority of people who have a wealth of money. We have a big amount of people who have no money. The question is, How do you make sure that everybody has an opportunity to live a better life?
Yeah.
That's it.
Yeah, we got that. Pralisha?
Just in response, Dr. Jacobs, over the 15 years, and I've worked on this bill from inception in terms of the Green Paper, you had a series of public participations with thousands of submissions, including from clients of ours, giving alternatives as to how this could potentially work. And none of them seemingly were seriously considered and now just discarded, as in no one presented alternatives, but alternatives were presented as recent as December to the President when he was implored not to sign the bill again. And so I just want to say that lots of suggestions were made as to alternatives, and so it can't be left or as a narrative that was not presented. Workable suggestions with huge economic backing and studies that were given to the state.
I think I'm probably one of the few people in South Africa who had looked at all of those submissions. So it's easy to say all of these submissions were all specific input into the bill. We had looked at those submissions. We took those submissions into account. You look at the bill, you look at the bill that was introduced to Parliament, and you look at the Act now, you will see where those changes are. And I think it's very important for us to do. It's not true, because we had 338,000 written submissions. And we looked at all 338,000 written submissions. How do you capture all of that into one bill? It's impossible. So we took the best of all of that.
Okay, let's move now to the alternatives. Dr. Mutudi, what do you think?
I'd like to concur with my fellow panelists that there has been a number of submissions made, and we believe that they were concrete.
Loud.
And if you want to, can they increase the volume? Otherwise, I'll be shouting.
It's on its highest.
And I just want to give a recent example, because we talk about a multi-payer system where everybody who has the ability to purchase is given that opportunity, whether you're talking from an official health funder like a medical scheme or an employer to be able to purchase on behalf of its employees. When we had COVID vaccination program, you would have a situation where you would have a number of people queuing at the same clinic or hospital, going for the same service. Nobody would be wiser about who's paying for that service. The person in front of you could be claiming from their medical aid. The other one is paid for by government, the one by their employer. Now, that's a system that we're saying could work. We've seen it work. There obviously has to be a bit more input in terms of how it would be structured. But the exclusion of other funders would actually not achieve what the intention is. And we're saying, make sure that you get participation. And Prof has been saying that in many countries, whether you look at Germany, whether you look at Japan, Thailand, you have employers participating, or those who are able to pay out of their pocket do so. And in South Africa, the situation that we have is you often have government saying that we spend. Government does not spend the 550 billion rand. There is money that comes from the fiscus, that comes from taxes, but the employers have got their own portion, medical aids have got their own portion. And we are saying do not exclude anybody else from participating. The outcome would be the same. The point of access of care would be the same. It would actually remove the inequity that everybody is complaining about.
Yeah. Do you want to quickly come in here? I'm coming to Zingiswa next. Kenneth? Do you want to just come in here? Because what they're saying is the exclusion means they can't be part of the whole.
Yeah, so I have a simple message, and I've been saying this message all along. Don't make it an us and them. Get involved, and I'm opening up an invitation here. Let's get involved in the discussions, and congratulations. I need to commend Sanlam for doing this. I think they're the first organization or corporate that has opened this up, that we start having a discussion like we're having. And I'm very thankful also, if I look at the panelists, they've selected a good panel. So it can either become where we talk about exclusion then in the end, or we talk about participation. Remember, there's a process here. this process will still unfold, which started with your first question about implementation. And I am saying there's still opportunity for a lot of discussions going forward.
So I can hook you up with all their numbers.
Oh, please do.
That's what we can do. Because what we have here now is an undertaking, right? That's what, Kenneth, we have an undertaking then, because what it means, because this is a collaborative process, or it should be. Okay, Zingisa.
David,
because
I'm
remember we're on
listening.
alternatives, right?
Yeah, I'm listening, but allow me, because I'm speaking from, I'm not on medical aids. I am not, I'm speaking for workers. And how I come in may be different, because when I'm listening and I'm hearing on the panelists, we seem to want to agree on this national health insurance and we think it's important, but then we've got profit issues, profit margin issues. Is it good for business? Would we be able, yes, no, allow me. Because this is what I'm hearing, that medical aids or people would not be able to purchase their own medical insurance or medical aid. I don't think the NHI says it prohibits people from that.
It does.
Okay.
It does.
Fine. Give me an opportunity. Because those that are worried are those that have been benefiting from it. But to those that have nothing to benefit from this discussion, who do not have access to health care, their voices are not important. Their voices are not being listened to. They are not being heard, Devi. And I think here we're taking a discussion that seems to be on profit margins than necessarily health that is accessible to the ordinary South African. And you may say you know about these 16%, 84%, but the reality is, and I was saying here, and I speak from experience, I was a worker who paid medical aid for 15 years. But when I had to go to the hospital to give birth to my daughter, I still had to pay service providers that were not paid by the medical aid, having not used the medical aid for 15 years to be hospitalized. So we must understand that the very same healthcare that you are purchasing, it is not enough. But South Africans, what we tend to do when we have discussions, we tend to make comparisons of ourselves with the developed world, and not in equal scenarios. For an example, we would say it has never worked in other developed countries. Are we a developed country? Yeah, we are not. But what are the conditions of South Africans? What is it that South Africa is unique about in difference to the other country? Why can't we make it work for South Africa? And this process, as Dr. Jacob was saying, it has not ended. We are still going to be making submissions. We're still going to make it so that everyone's voice is incorporated. And it's not as if government woke up and said, we are implementing the NHI, or the president is signing. There's been consultation, there's been views that have been taken. But we must also understand that COSATU, for an example, we represent Samatu, doctors. Have we had an opportunity to speak and ask them, what does NHI mean? We are representing DINOSA, which is nurses. We are representing workers that are working as your porters in hospitals. Yeah. Have we had a conversation and asked them, what is your take on national health insurance and how is it going to transform the healthcare system that you are working on? What about the graduates that are sitting at home who are not employed now, that the NHI could also provide an opportunity for them to be employed?
You see,
so
Zingisa, you are raising important points, very important points. So my question is the NHI as it's proposed right now, is that going to be a magic wand and is going to solve all those problems?
Devi, nothing is a magic wonder. Nothing is a magic wonder. And I am happy what Mpho was saying here when he introduced this discussion. He said South Africa always finds solutions. The problem is when we start sitting in our own comfortable places and we look at others and we look at ourselves and we say, this pie will never be enough. You are never full before you can even eat already you are looking at it and saying, if you take 10% of it, it means I'm left with 90, and then somebody's going to take. You are not even appreciative of the 60% and say, how do we make sure that the 60% that I will be left with still ensures that the health system in this country is transformed? What about the poor people? Women are dying in the public health care, even in the private health care.
Can I
talk
about
let's give
can
you
I talk
a
about the
chance.
NHI and the specific issues that has got an impact on your last point? In section 58, Dr. Jacobs, there's a section that excludes maternity cover.
Maternity cover?
Yes, there is a section that excludes.
Not in section 50.
And you go read it, section 57. What it does.
Can I clarify?
What it does is that as soon as you implement it, if you are a pregnant woman and you are on a medical aid, section 4 of the National Health Act says that if you are on a medical aid, you cannot get free care, unlike everybody else who's entitled to it, like when the late President Mandela decreed, right? If you are on a medical aid, you cannot get free care from the state. Now, the NHI then says, for any service that is provided under NHI, for those that are on the, for any service that is provided a fund, cannot be paid for by a fund. That excludes maternity cover. It would mean that pregnant women would have to pay out of their own profit.
No, I think Prof is confusing something.
No, I'm not confused.
No.
Section 57.
Can I clarify the point?
Clarify?
Yeah, so what this deals with is the amendments to other pieces of legislation. So in those, the amendment to the Medical Schemes Act includes an amendment to the what's called the business, what's called a relevant health service, which relates to the business of a medical scheme, which refers to that. So medical schemes can only cover relevant health services. So what's happened is it deleted the sections that refer to reproductive health care in that immediately. It's not related or talks about the other sections which say if this is covered by NHI, you can't cover it through a medical scheme. This actually just removes reproductive health care from medical schemes the moment that is signed. This is utterly absurd.
Have they misread the situation
They've
here?
misread the situation.
Sorry, it's in legislation.
I think,
and it's just the deletion.
I think they firstly dishonoring the father of our nation, Tata Nelson Mandela.
No.
And I'll tell you why I'm saying it, because it comes to reproductive health. Remember that before people didn't have free public health care. You had to pay for it.
Kenneth, you're doing that thing again. Is it true what they're saying?
No, so I'm saying why I say they're wrong.
Yeah,
I'm actually explaining to you.
Let's start from today, but not from like 20, 30 years ago.
No, I'm saying that we had instituted free health care for all pregnant mothers, and we've instituted free health care for all children under the age of 6, if we can remember that.
Yeah, but now.
That is not true, because we are stating why we removed the words reproductive health. It didn't have anything to do with maternal care.
It does. It removes all those provisions.
So they misreading it in between what's in the Act and in the transitional arrangements.
No, but it's written in English.
Yeah.
It expressly removes the provisions so that a medical scheme is effectively not permitted to reimburse any maternity services, including termination of pregnancy. So that is all what is explicitly deleted. Now, the assumption would be, I'm interpreting from what's being said, is that somehow this is available in the state. But the point of why somebody contributes to a medical scheme is because, first of all, they're not provided for in the state. Their services are not available for medical scheme members. And I'll give you just one instance. Provincial health departments are not funded for medical scheme members. The provincial equitable share allocation given to provinces deducts medical scheme members from the allocation. So there's no services there. Now, if somebody wants to be covered through a medical scheme for reproductive health care services, they should be permitted to do so. This just removes that immediately, not as a transitional measure.
So Here's my thing. I have to take 2 questions from the audience, right? We could go on talking. What I love, though, is I love the passion that everybody has here in wanting this to work. I think it may have felt very much like an attack, Kenneth, but what I can see is the nuts and bolts being really squared off here. We'll talk about how you feel later, but that's what I'm saying. Quick point, and then we're going to take questions, and Paul's going to handle that.
Only because I want a productive engagement with Dr. Jacobs later. I want to help him out a little bit here in that and it adds to the lack of the picture. What needs to happen is we need regulations to be passed, which includes maternal health, before we can bring that section into effect, which removes reproductive health, because that's a section that's not yet into effect. So many things have to fall into place before it is indeed covered. So the minute that strikeout takes effect is when that provision is brought into effect. But it's a very long time, but the problem with that is too many things have to happen before even to set up the fund. So just to say that the picture is very blank for a long time, and these issues do crop up the longer it takes.
Paul, we can take 2 questions from the audience.
2 questions from the audience. Please put your hand up.
And keep it short and sharp, right?
We've got a question from Gwede. Papa, what is your name?
It's Gwede, as we've said. Gwede is in Pretoria. Question. Listening to the panel, Prof and Doctor, we heard that there's a crowd which is taking government to apex court. Are you going to join that litigation, given the fact that, Doctor, we are saying engagements are allowed to move forward from the steps up to the end? What is this litigation about? Is it to protect President of COSATU, their narrow interest, their pie, or what is it? If you could clarify that question.
So we're getting a little bit of feedback, so it's not 100% easy to understand you, but what you're saying is that there are concerned groups that have taken government to court over this. Is that what you're saying?
Yes, whether or not they are supporting that, so that my question is not misrepresented and interpreted.
So why don't you just say it one more time, then we can hear and slowly. A slight reverb.
Maybe my Bantu education will assist.
No, it's not that.
My question is simple. There is a crowd or a group that is taking government to apex court. Are you joining that crowd? And for what good reason, given that space for engagement is still there to discuss on the implementation of NHI? Was it clear now?
Yes, thank you so much. We can hear now. And you addressing that question to whom specifically?
I can take it. I can take it. Yeah. We are part of the crowd that we are referring to.
You are the crowd.
We have petitioned the president to take the act back to parliament, because it's an act. You cannot, through regulations, change what is in the act. And we are saying that there are some aspects of the act that needs to be amended to make it workable. So we are not joining, we're actually one of the groups that took the president to court.
Alex?
So I'll deal with the issue of open to engagement. Okay, from 2009 to this period, virtually nothing has changed in the proposals. There's been no learning in the process. There have been no documents or policy assessments or systematic analysis or evaluations produced. Nothing that is actually involved engaging with the environment and the world as it is to look for what our next steps should be to improve our system. That is not how you reform a system. It's been a closed process from day one. It's either you accept this or we'll ignore you. That's been the nature. It's been a top-down process in a closed conversation in which there's no informational input that's taken into account to improve the policies. And that's why we've had no reforms for 20 years.
We're going to take one more question, and then we'll start to
Before you do,
summarize.
I've been in a hot seat and sweating. He's been in, he didn't answer the question. Is he
Tell
part
him
of the group? Are you also taking us to court?
I can't take people to court.
That's the question.
Okay,
Right,
next one.
We've got a question here from former Miss South Africa runner-up, Karishma.
So, can you hear me okay?
Yes.
So early in the discussions, there was this divide, like, the people that can afford and can't afford. But I believe we do have a public healthcare system, and we have a private healthcare system. But it's about how both of them are run. So has government looked at where funds are directed in the public healthcare, if it's directed to the correct place, and if those places are correctly run, because they are available. So where is that money going to? Because there is money going in, and now you're saying you want a central pot for all the money to be going in and distributed, but then where is that money going to go to?
Simple, all the money is going into one pot.
She said that. What she's saying is...
So
yeah.
The little money you're talking about, which is half of the spend in South Africa, is going to 42 million people. The other half is going to 16 million people. And I think that's where we keep on missing the point.
No, you missed the point. 50% of that money is people's post-tax disposable income. It's not government money.
Not state fund.
You see, this is a challenge in South Africa. Even though we said we could come together during COVID, this is the problem that I have. It's always those who have more who are using arguments like these to prohibit those from who don't have to get the health care that they require.
Yeah, but we can't also keep knocking those who have more, because then they'll have nothing.
But we keep on being knocked that when we make those statements, that these statements are not appropriate. But it's so appropriate. It's the essence of the understanding of what healthcare ought to be.
That's a nonsense.
Okay, here's what, let's all play nicely now. We've done very, very well. Let's do this. Because government is running this from the front, can I have your top 2, top 3 most important points that you think government needs to take into consideration? Because what we're not arguing, I've said this before, we want this to work. We just want to iron out all the problems. I don't want to go to state hospitals and hospitals anymore and go skill them in there and go look for the manager of, it's just I can't, I'm getting old, guys, right? So what should government be really concentrating on? Let's take it from you, Alex.
Okay, so first of all, let's be clear. Whether or not an act is signed or not, it's not going to be implemented. Virtually nothing is going to happen for the foreseeable future, our lifetimes, in terms of this act. The problems that lie with our system lie in how we're running our public system and how we're regulating our private system. The health market inquiry gave detailed assessments of the corrections to the private health system. Not one was implemented. So that needs to be dealt with. There's not a single process going forward on that. Public sector, you look at the examples of Babita Deokaran and the rest. The public health system is a sieve. The money goes in and it pours out. Governance is basically broken in the public health system. If it is not corrected, it'll continue. And the NHI proposals do nothing to that. So we have to prioritize governance reform in the public sector. We have to implement the health market inquiry recommendations in the private, and we have to harmonize the two systems. That's the only way forward. The NHI Act is basically a fiction.
Felicia?
Sure. Alex ended on a high there. Mine is going to be slightly more participative. I mean, to say to, Dr. Jacobs, listen to the submissions made. Don't take us from a point of suspicion or protectionism. There is I think, inherent desire for the system to work, a workable healthcare system for all. But there is this constant reception of the private sector by the state with suspicion and then with disdain and no collaboration. We have an example of COVID. It worked. And so can you now listen to the submissions we make from that point of view?
Can I get now to Dr. Mutudi?
I just want to add on to what she said, that we need to deal with the trust deficit. And we must start with meaningful engagements. I think we spend hours and a lot of money on submissions that were ignored. So when we do engage and we want to engage, the engagements must be meaningful for a combined outcome.
Sigiswa?
Thank you very much, Devi. I want to start from where the doctor ended on the trust deficit. I think we need to deal with that. I've seen a lot of trust deficit at net level. Private sector sometimes does this. Tomorrow you can't hold them to account. It's a problem. So trust deficit on both ways, private and private sector. Secondly, it's collaboration. Collaboration of the private and the public sector is going to be important for us to ensure that we are able to have this national health care comprehensive coverage in our country that is able to protect the most vulnerable, but also to ensure that we are having a preventative healthcare system in our country. And for me, the emphasis is the trust and also the collaboration between the private and the public healthcare sector.
Nice. Yeah. Kenneth, you get the last word. I think you deserve it.
Oh, thank you. So the act is there. It's called the NHI Act of 2024, of 2022.
2023.
The point is that we cannot wish it away. It's there. We need to work with what we have. The intention is, and to take the words of the collaboration and the desire for workable solutions, etc., let's do that. Let's work at the trust deficit. Let's invite everybody to discuss, not to create an us and a they, and let us rather put aside our own expectations of what it has to have and consider those who don't have, so that we're able to build an equal society in our country.
Thank you. We are very special as a people, I can tell you that, because somehow or the other, through our diversity, we'll find a way in which we can make it work. I'm going to hold you to that in the terms of...
Got my phone number?
Yeah, I've got your phone number.
WhatsApp me.
Yeah, I've got you. So that we all sit around the table and let's table these positions, which I know a lot of you have been making clear for a very long time. To all of you, thanks for being such a fabulous audience. I think what we've been able to do here today is take the discussion somewhere as opposed to nowhere. Thank you very much.